I think we have to start the next session. It is a very important session about the latest clinical trials related to hypertension. We are in an era of evidence-based medicine. Some trials are cornerstones in changing our way of thinking for the management of hypertension. The most important example for that is SPRINT trial. Although it is a single trial, but it was a very important role about the change in the definition and classification of hypertension. And that's what Dr. Karim Saeed will speak about, which is the SPRINT trial. Karim.
بسم الله الرحمن الرحيم. صباح الخير. And thank you for the invitation. As Dr. Omar said, SPRINT trial, which is a landmark trial published in 2015, was a landmark trial in defining the target of blood pressure, and it caused change in the guidelines. However, after its publication, there were major questions and concerns regarding its results. And during these 7 years, we had many publications trying to answer these questions and to solve these concerns. And this is the core for this presentation. In a nutshell, the SPRINT trial, which was the largest ever trial published to study intensive versus standard treatment targeting asystolic blood pressure less than 120 versus 140, recruiting more than 9,000 hypertensive individuals. And it included patients at a higher risk for cardiovascular event, those with established or subclinical cardiovascular disease, those with CKD, those with high Framingham risk score, and those above the age of 75. And it is important to mention that it ruled out diabetic patients and those with stroke and those with gross proteinuria. We can summarize the results in 3 slides. The first slide, intensive arm was associated with significant reduction in blood pressure per protocol with a median pressure 120 versus 136 in the standard arm. And this was associated with significant reduction in primary outcome, which was a composite of myocardial infarction, stroke, and heart failure, in addition to cardiovascular mortality, 25% reduction. And the study was prematurely stopped because of these results. And 25% reduction in total mortality with intensive treatment. In totality, there were no differences in serious adverse event between both arms. However, intensive treatment was associated with increased risk of hypotension as expected, electrolyte abnormalities, and acute kidney injury. These were the major summary of the trial. And as you know, it caused change in the guidelines. The American guidelines lowered the target to 130 systolic. However, as we mentioned, we had some questions related to the technique of blood pressure measurements and the impact of early discontinuation, and some concern related to heart failure outcome in this trial and increased risk of acute kidney injury, and whether intensive treatment may slow the progression of chronic kidney disease. For the first concern, as we know, the SPRINT used a novel technique in the blood pressure measurement. They used automated device, which is common. However, in absence of physician or staff in the room during measurement, in addition to the other standardized technique. The aim of this technique or method to avoid the white coat effect. However, there were some concerns whether to translate the finding of this trial measured by this technique into the real world with office blood pressure measurements, knowing that some studies showed the difference between office and automated blood pressure measurement is 15. And we don't have data whether the difference remains the same in the presence of an attended blood pressure measurements. And in some individuals, the difference may be up to 40 millimeter mercury. And some argue that the 120 millimeter threshold for intensive treatment may stand for 130 or even 140 millimeter mercury in office. And actually, this was the rationale why the American Heart Guidelines chose the threshold 130 and not 120 for a target blood pressure. This issue was analyzed in analysis by the SPRINT investigator when they compare the measured systolic blood pressure using the SPRINT protocol versus office blood pressure for more than 3,000 SPRINT individuals taken from the health record before or during recruitment in the study. And they found that for the intensive arm, the difference between post-modality is about 8 millimeter. And this lies within the empirical 10 millimeter threshold given by the American Heart to define target blood pressure. So it looks it's okay to use the plus 10 over the 120, but this may not be the case. Further analysis showed that in the same analysis, this 8 millimeter is okay when we consider the whole population. But when we look to the individual difference at the individual person, we'll find major disagreement between office versus SPRINT protocol for blood pressure. And as we can see here, the agreement at the 0 exists, but for some individual, the difference may be up to 45 millimeter mercury or lower down to minus 30 millimeter mercury. Actually, in 20% of individual, the office blood pressure is lower than the automated method used by the SPRINT. And in another level, there is wide variability of both techniques at the same individual. So the difference between office versus automated pressure at the 6 to 18 months during the study showed very poor correlation with the difference with the two techniques at the same individual at the 36 months during the study. So they concluded that these results highlight the importance of proper blood pressure measurements and the inability to apply one common correction factor, the 10 millimeter factor, to approximate research quality blood pressure estimate. So the only way is to adopt the technique used in the SPRINT to get the same results. Otherwise, we will over-treat our patients and will get more hypotension and serious adverse events. The second concern is related to the early termination of the trial. Early termination means less adverse event and less positive outcome. And so we do not know the true impact of the intensive treatment on the outcome. Also, early termination means short follow-up duration and uncertainty related to the long-term outcome of this trial. Actually, the proposed follow-up period in this original protocol was 5 years. It is terminated early, leading to follow-up up to 3.3 years median. And last year, we have the final report of the SPRINT trial. And it included within the manuscript an added 1 year observational post-intervention period. So we are approaching now 4-year follow-up. And the investigator were asked not to stop the trial medications unless there is safety concern. Of course, there was increase in the blood pressure in both groups, +7 in the intensive and +2.5 in the standard arm. And we had a red flag. There was increase in the incidence of acute heart failure in the intensive arm group, opposite to the original data. And the author explains that due to the less common use of diuretic and ACI and ARBs among the intensive arm versus the standard arm. However, as I mentioned, in the majority of patients who developed heart failure during this year, there were no changes in the medications. But in the totality, when we combine this 1 year plus the randomized controlled trial period, there was no change in the heart failure incidence, and still we have the 25% reduction in the primary outcome, including mortality. Actually, the concern related to the heart failure raised immediately after the publication of the original trial in 2015. As we can see here, the major driven for the improving the primary outcome in the sprint is reduction in heart failure, not reduction in stroke, not reduction in the myocardial infarction, which was very strange. And some authors believed that the reduction in acute decompensated heart failure in the trial was related to the difference in the use of diuretic in both arms, with excess use of diuretic in the intensive arm, and this will lead to masking the heart failure symptom, while in the standard arm, the less use of diuretic will unmask a latent heart failure. And this was true. Actually, as you can see here, there was significant difference in the use of thiazides and loop diuretic in both arms. And this was an issue for analysis by the sprint investigator, looking for the potential role of diuretics in the outcome, change in the diuretics. First, they highlighting that the occurrence of heart failure in a hypertensive individual in this trial was associated with 10-fold increased risk of total mortality and the 25-fold increased risk of cardiovascular mortality, highlighting the importance of prevention of heart failure, including blood pressure reduction. And among the 400 participants in whom there was withdrawal of the diuretic during the trial, non-developed or minority developed heart failure during the follow-up. And heart failure did not develop immediately after withdrawal. And diuretic use was not an independent predictor for the development of heart failure. So they concluded that diuretic difference used in the trial should not be claimed to be responsible for the difference in the outcome. And in the final report, this irritant issue was taken seriously by the investigator, so they censored the heart failure outcome from the primary outcome, and still we had the 25% reduction in the primary outcome. However, the increased rate of heart failure at the 1 year follow-up is still a red flag in this trial. Intensive treatment was associated with 1.6-fold increase in the risk of acute kidney injury with intensive therapy versus standard. And again, this was a core for an analysis. And they showed that the majority of acute kidney injury defined as increase in the serum creatinine more than 0.3 milligram per deciliter occurred in 50% in the non-CKD cohort and in 70% in the CKD cohort. So it is a mild acute kidney injury. And in 90%, it is completely reversible. And in 5%, it is partially reversible. And in the remaining 5%, they will need dialysis. And half of these patients became dependent on the dialysis. Unfortunately, the mere occurrence of this rise of creatinine was associated with worse outcome in terms of the sprint primary outcome and total mortality. So it is important to identify patients at increased risk of AKI. This will include male patients, Black patients, those with low AGVR at baseline, patients with underlying cardiovascular disease, elderly patients. And interestingly, neither the use of diuretic or ACI increase the risk of AKI. Now we have an important question. Does lowering the blood pressure to a very low level slow the progression of chronic kidney disease? In the sprint, we have two cohorts. The non-CKD cohort, those with AGVR less than 60, and the CKD cohort between 60 and 20. They studied the progression of CKD by looking to the magnitude of decrease in the AGVR in the non-CKD defined as 30% reduction in the CKD defined as more than 50% reduction or development of end-stage disease, dialysis, or transplantation. In non-CKD, which is the majority, intensive treatment is associated with increased risk of deterioration of the kidney function compared to the standard treatment. And this occurs very early during the first 6 months related to hemodynamic disturbance. On the other hand, the benefit at the cardiovascular level is sky high. So in order to get one mortality benefit, we have to treat 38 patients for 3 years to prevent one mortality, but we will have 1.2 increase in the risk of asymptomatic, usually mild incident CKD. For patients with CKD, the situation also, intensive treatment will not slow, but it will not deteriorate the kidney function. It is important to mention that the CKD population had mild CKD without significant proteinuria, and diabetes was excluded. So the same rate of deterioration of kidney function. But more benefit in terms of cardiovascular outcome and mortality, and the more increased risk for AKI. And this explains why the recent KDIGO guidelines recommend a target systolic blood pressure less than 120 in patients with CKD. This replaces the old 140 and 130 in CKD, using the standardized office blood pressure measurement and not the SPRINT protocol, obeying the AHA standardized method. So I'm now on time, and this will be my last slide. Thank you for your attention.
Thank you, Karim, for your illustrative lecture. I think this is for the first time that one trial can change the guidelines, at least the American guidelines and the European, although they didn't change the classification, the numbers, but they advise for less conservative management of their patients. Do you think that the new American classification can be applied in a country like our country, or taking into consideration that applying these numbers and measurements increase the prevalence of hypertension from 30% to 50%? That means that we have to treat about half of the population. What is your comment about that?
For the first point, yes, changing the definition of hypertension will increase the prevalence of hypertension. However, this is a usual story in the field of hypertension. Hypertension definition is usually a moving target from decades. This is a point. Whether to translate the change in the definition into a change in targets and the threshold, this is another story. Patients is at risk from a very low systolic and diastolic blood pressure starting from 100 and 110. Whether we can apply the AHA guidelines in our country, it is very questionable. Actually, it is very questionable to apply the SPRINT threshold even in the Western country, and many authors believe that it is very fancy to adopt such thresholds. And follow-up studies showed that it is not possible. Actually, in the trial itself, this 120 in the intensive arm, it is the median, and it is not the mean, meaning that 50% of the trial population actually had a blood pressure more than 120. And only 50% has those pressures less than 120. So I'm not sure whether we can apply this ever in very strict situation using the strict technique. This is my answer.
Taking into consideration also that most of the physicians treating hypertension are depending on the number only, and they are not taking into consideration the risk classification of the patient, and there is a great difference for that.
Yes, this is a time now to change our mind for how to manage hypertension. We should manage hypertension as we manage dyslipidemia now. Take the number of the blood pressure and put it in a score or a chart to come with indication, starting pressure and target pressure.
كريم يعني طبعا excellent review للسبرنت ترايل، وهو فعلا زي ما انت قلت ان immediately بعد الترمينيشن او premature termination of the study الامريكان guidelines came with that lower blood pressure for definition of hypertension. لكن هي لفت نظري في الديزاين كذا حاجه. اولا هم اختاروا فعلا الهاي ريسك جروب اللي هم فوق 75 سنه، لكن هم excluding ان العيان يكون diabetic. فهم انا مش عارفه ايه الكونسبت في دي، لان احنا اغلب البيشنتس، مش هقول كلهم لكن اغلب البيشنتس الهاي ريسك اللي بيوصلوا للايج 75 most of them بيكون developed some sort of diabetes or impaired glucose tolerance. دي نمرة واحد.
يكونوا developed
most of patients اللي reaching 75 years of age هم بيكونوا diabetic أو عندهم some sort of impaired glucose metabolism. دي نمرة واحد. نمرة اتنين إن reaching 120 هم ما جابوش سيرة في الاوتكم بتاعهم. هل في أي إفكت على الكوجنيتيف فانكشن؟ زي ما احنا ما ينفعش، يعني كان في محاضرة حلوة قوي امبارح من دكتورة ماجدة من قناة السويس سايكاتريست، اتكلمت على ان البيشنتس اللي عندهم هايبرتنشن وهم اولد ايج بيديفلوب سو اند سو اند سو، لكن lowering blood pressure below 120 I think this is very difficult to reach in such age group. ويمكن عشان اوصل لها محتاجه invasive blood pressure monitoring اكتر من كونها مجرد الكترونيك علشان الاثيروسكليروزس وكل الكلام ده. ف I don't know ايه الكونسبت في ان هم don't involve الدايابيتس اللي محتاجين اكتر ان هم يبقوا lowered have lower blood pressure والeffect on the cognitive function of such population.
Okay, thank you, Azza, for these questions. Actually, السبرنت هي الميرور of the accord. Accord trial, nearly the same trial done in diabetic population, and it was a negative trial. Intensive blood pressure reduction in diabetic population was not associated with significant improvement in the outcome versus standard. So it was a time to do the same design in non-diabetic population, and it showed difference. However, in subgroup analysis in the sprint trial, for those patients with impaired glucose tolerance, the primary outcome were reproduced. And we have many questions and concerns related to the design and outcome of the accord. There was the reduction in the stroke in the accord, and so the European guidelines lower the threshold for blood pressure management in diabetic patients despite the result of the accord trial. This for the diabetes. For the cognitive dysfunction, there were some analysis. However, they are waiting what is called the spring ask trial, A for Alzheimer, waiting its results, taking into consideration the same concern you have mentioned.
دكتور فتحي بينبهني لحاجه مهمه، ان يعني طبعا احنا امبارح اتاخرنا جدا. we have to be strict in timing، بس انا مش هقدر امنع نفسي بان انا معلش ان انا هاخد سؤالين من الدكتور محسن بيه والدكتور حسين، وبعد كده في all the lectures later on we'll be sticking to the time. دكتور محسن بيه.
اعتقد ان السبرنت ترايل دي يعني we cannot use the information فيها in our everyday practice. Major limitations طريقة قياس الضغط. We use the automated office measurements، ودي حاجة يمكن نادرا ان احنا بنستخدمها عندنا هنا في مصر وأماكن كتيرة في العالم. ولو ان recent European guidelines they recommend that we use the automated office، انما مش دي الطريقة. والاوتوميتد اوفيس ده بيدينا قراءات مختلفة اقل عن الطريقة اللي احنا بنقيس بيها. الحاجة الثانية البيشنت population، دي كانت selected patient populations elderly وفيهم high risk، فبالتالي ما نقدرش generalize الاوتكم بتاعة السبرنت ترايل ونحطها in our guidelines. فلابد يؤخذ في الحسبان طريقة القياس ونوعية المرضى اللي كانوا موجودين in these trials.
حسين يسأل سؤال.
There is one important thing about the generalizability of data also. All patients before entering into the trial were adjusted to achieve either the high pressure or the 120, and only those who can achieve both were randomized in the trial. بمعنى if the patient was impossible to achieve the 120 target, it was not randomized in the trial. So this result is not generalized. It's not. One question, please. Are you aware of any joint meta-analysis at case record level of sprint and accord together?
I think افتكر انا شفت حاجه كده بس ده من سنين من 2015 و16 لما كنت بشوف الترايل عملوا combined analysis الاكورد والسبرنت وكانت الداتا toward السبرنت among the whole population.
Thank you, Karim. احنا because of we are delayed in time, we call for the next speaker.